vascular complex. These are the types C2 and C3 of the AO classification, and the 3, 4, and 5 types of my own classification. CT scans have substantially improved the understanding of the patterns of articular disruption. Together with experimental findings, more accurate classifications are now available. Described experimentally in cadavers a classification of intraarticular and extraarticular fractures, and stressed the importance of the ligament insertion origins in their displaced fragments based on the direction of the acting forces. Bain and Associated found that the fracture lines do not enter the ligament attachments on the distal radius. They pass between them. And what they do, these attachments reinforce the bone and form an osteoligament unit with a fracture fragment. These are all articular fractures. In 2016, Brink and Rickley came up with a 4-corner concept, which is in a CT-based assessment of fracture patterns, distal radius. And they came up with 4 major corners: radial, dorsal, volar, and ulnar. And again, the critical fragment that displaces or causes the shift of the carpus is now called a key fragment. So summarizing, the articular patterns that you see depend on the direction of the acting forces and also the location of the ligament, radiocarpal ligament insertions on the distal radius. Hintringer in Vienna, a good friend of mine, combined all these new concepts and brought up a new classification, which is beautifully illustrated, but most important, it's very comprehensive and treatment-oriented. He describes an extraarticular group with dorsal or volar displacement, and then an intraarticular group with partial articular fractures. I call now key types, and we have 6 different key types of partial articular. This would correspond to the B group of the AO classification. And the non-key types are the complete articular, and here we have another 4 different types, and I will show these now in detail. He found that for the partial articular fractures, 6 different patterns are found, and at least 1 corner of the distal articular surface is in continuity with the shaft. And again, the key corner constitutes the stability of the carpal bones that displace with the fragment. So if we go to see the 6 key types, this has been studied with plain X-rays, CT axial, sagittal, and CT8B cuts, as well as 3D reconstruction. So we have the volar radio-ulnar fragment, which is depicted in red here. This is the part of the joint surface that displaces. Then we have the volar ulnar corner, the volar rim, very little thin corner, but very dangerous because it's the attachment of the short radiolunate ligament, the radial styloid key fragment, the dorsal ulnar fragment, and the central impacted fragments. So the non-key types, which being the complete articular fracture or the whole involving the whole surface, is the distal shear, very distal shearing fractures of the joint surface, the 3-part, or this would be the 4-part fracture of Charlie Malone in the older classifications. Then the comminuted, more than 4 or 5 parts, an impaction of the joint surface. And the severe comminuted would be those which also extend into the shaft of the distal radius. So what we're going to talk about is about the management of the compression fraction of the joint surface, 3-part and comminuted. The multifragmentary volar shearing fracture, as you can see here, which is very problematic because actually it includes this volar ulnar fracture. And again, as I said before, the radiocarpal fracture dislocations and the combined injuries, high energy. So how do we manage these? The fracture reduction, you can do it with manual reduction, indirect reduction with ligamental taxis. This can be done by putting a fixator, external fixator temporarily to the wrist and applying longitudinal traction. Or I can use finger trap longitudinal traction in the operating table, or traction vertical. If you're doing, for example, arthroscopic assisted reductions, you can use longitudinal traction, but in the vertical position, or a combined method. So, sorry. So the management, the different fixation modalities we have for these fractures are volar plating through the volar approach, fragment-specific fixation through different approaches with smaller implants, bridge plating, and external fixation. Remember that you always have to treat the associated lesions at the same time, and this implies that DRUJ, carpal ligaments, carpal fractures, nerves, tendon, can combine soft tissue injuries. Otherwise, you don't do that, you might end up with a complication, as you can see in the right side of the slide. So the volar locking plating to the extended approach will be used for irreducible fracture, displacement, nascent malunions, and established malunions. This was described by George Orbe in Miami. He actually modified volar approach of Henry. First, you have to do a release of the distal sheath of the flexor carpi radialis tendon. Then we release the first dorsal compartment from the palmar side to mobilize those tendons from the bone, and also do a tenotomy of the brachioradialis tendon. You might need to pronate the shaft fragment out of the way to present the fractured area. And in that way, you can actually see all the fragments, volar and dorsal, and reduce them against the carpus, interfocal exposure. Here you can see an example, very displaced fracture complex with a fracture of the distal ulna, treated with a volar locking plate, and the fracture of the ulna with a tension band wiring. Remember always to start first reducing the ulnar corner or the lunate facet fragments, and then secondly bring up the radial styloid fragment up to the scaphoid and reduce and pin that temporarily. Then the plate is applied, and again the plate can be used as a volar buttress to reduce the whole distal radius on top of the plate, because it is anatomic and conformed to the normal anatomy of the radius. It helps a lot to get the right reduction. And then fixation with the plate. I will come to the volar rim fractures or volar fracture lines, which are distal to the watershed line. And these are a problem because usually the conventional plates will not capture those fracture lines which are distal to the watershed line. So you might need to use a volar hook or a volar plate with a hook extension to catch that fragment. Actually, you can go on top of the caps. That's the insertion of the short radial lunate ligament. And if it's unstable, the whole volar, the whole carpus might be placed into the volar position. So this is the typical case that you can see that volar ulnar rim fragment, which is there, which is very problematic. If you don't capture it with a plate, this happens, like it's in this case. You see, you have the whole carpus is now displacing to a volar side. It's an unstable situation. So here, volar rim plate was used that goes on top of the volar rim of the radius. But if the carpus, after putting the plate, remains unstable, then it's better to transfix the lunate against it, as you can see here, with a K-wire for 6 weeks. That's a volar rim plate. And since it might give you flexor tendon tendinitis at a later date, you might need to remove them. If you have isolated fragments, as in this 2 cases, there are smaller plates, fragment specific, specially designed for the volar ulnar corner or for the very small ulnar rim fragment with these hook plates. Again, as you see in this case, there was this additional transfixion of the lunate to the radius temporarily to prevent subluxation. Fragment specific is the independent fixation of articular fractures that do not respond to the fixation of a volar plate. These are smaller implants. You can use whatever these 3 incisions that you see here, extended dorsal approach, Henry volar approach, or the carpal tunnel extended approach that we will use if you want just to fix the volar ulnar fracture. So this one is a radiostylate dorsal margin and distal ulnar fracture. You see, very displaced, very unstable, and because the main displacement is dorsally, you will use a dorsal buttress plate, as you can see there, dorsal ulnar, and a radial column plate. The ulnar fracture was also fixed. Here, another example where that irreducible dorsal fragment is unreducible because it's completely rotated towards proximal. So here you have to go from the dorsal side and from the volar side to do this fragment-specific fixation. The high-energy injuries extending to the shaft usually require a combination of internal fixation, bone grafting, and sometimes temporary fixation of with external fixation. But sometimes you may use a longer implant with fixed angle devices, which are bridging the comminuted area, and very rapidly callus formation will come because you have respected indirect type of reduction. Don't forget to use intrafocal reduction if the articular part is difficult, as in this case. This is a typical case with a lot of soft tissue swelling. So for these, you put a fixator first, wait for the swelling to subside, and then at that time you can do imaging, and you can see there's an impacted central fragment there, which is non-reducible from the volar side. So here, 2 incisions were used, temporary fixation of soft tissue, and you see that the skin had to be grafted because of the massive swelling. And lastly, the bridge plating, as you can see in this slide, together with external fixation, will be used for severe non-reconstructible comminuted fractures. So these are the fractures that respond very well to traction. And here you see an example with a bridge plate between the 3rd metacarpal and the radius. The very distal shearing fractures can also be treated in this way. It's very easy. You can see here an example, distal shearing fracture, bridge plate, and here you have an anatomic reduction. So the external fixation, again, remember, it's a very useful tool for the comminuted intra-articular open and infected fractures and very distal shear fractures. So don't throw them away. The treatment modality is a valid alternative in the treatment of complex disc trauma. As in this, there's nothing you can do that put a fixator if you have to deal with this type of soft tissue problems. And here I see a very distal shearing fracture treated with external fixation and limited open reduction with screws and springs with a very good residual function. So in conclusion, we can say that in these In these fractures, articular reconstruction may be difficult, but is possible within limits. Often you need a double approach and distal ulnar fixation. Remember to treat the associated ligaments at the same time. Then recognize the non-reconstructible fractures for the ones that will use external fixation or bridge plating. And have in mind, consider secondary radioscapholunate fusion as a salvage. Having reached a consensus in this problem, look at this. Consensus means that lots of people believe collectively what nobody believes individually. Thank you very much. Thank you very much for your time.
Thank you, Professor. It was a wonderful talk. You have made the complex fractures look very simple. We wish we had more time to learn all about distal fractures, but we do have some questions from the panel members. So the first question from my end. So what is your sequence of fixation, Professor? You fix the radial column first, the ulnar column first, go dorsal first, or fix the ulnar first? What is your sequence of fixation?
The sequence is, as I showed in one of the cases, you start always with the intermediate column, meaning that you will try and get the sigmoid notch fragments that go together with the volar ulnar and dorsal ulnar fragments, the intermediate column of Ricci and Regazzoni. That's the main, see this, it's the stone of the arch of the wrist. So it's very important to start there. Then you do the radial stylo, and then after you take care of dorsal fragment, if it's not reducible from the volar side. Usually when you have the plate put on and you do traction and volar flexion, you might get then a good reduction with traction of the dorsal ulnar fragment. And then you can fix it from volar to dorsal through the last pin in the volar.
Okay. Prof, we have a question from the audience. What do you do with the loose osteochondral fragments, which has no attachments?
If it's very small, if you do an arthrotomy, usually an arthrotomy you do if you go from the dorsal side. If you do arthroscopic assisted, it's not a problem, because there you can see all those little pieces that you can wash out. So if it's not a sizable osteochondral fragment, if it's a very big defect or a considerable defect for the joint, you will try to reduce it and fix it. But the only way of getting those fragments is through the extended approach with pronation of the distal fragment from the volar side, that you might get and reduce everything against the carpus, or use arthroscopic assisted or a dorsal arthrotomy.
Okay. Thank you, Prof.
Yeah, I have a question, Dr. Diego. In a combined distal radius and ulnar fracture, what would be the sequence of fixation?
If the distal ulnar fracture is displaced and shortened, it's better to fix the ulnar first. Exactly the same as you would do for a pilon fracture of the ankle. Remember that we used to start fixing the fibula and then bring the whole tibia back to the talus. So usually it's a simple fracture, it's not very comminuted. Then put a stable plate on the ulna and then bring the intermediate column to the head of the ulna, and then the radial styloid towards the radial side.
Professor, after you fix it, you find that the DRG is still unstable. So how do you know? Is it because of the incongruity of the sigmoid fossa, or is it because of a TFCC injury? So how do you really look into the dorsal?
Okay, if you suspect that if you have a lot of initial displacement in the radiograph, and actually the distal radius is way separated from the head of the ulna, then there is an obligatory lesion of the TFCC. It could be radial, it could be peripheral, but the disruption is there. And then you reduce the radius and you check the stability of the ulna. And if it's acceptable, a little ballotment you can have. But if it goes back in place and it's stable and the radius is anatomic, if you reduce anatomic with a volar plate, so it's out to length and the sigmoid notch is congruent with the head of the ulna, then I will protect that for 3 weeks in a sugar tone splint to control pronation and supination. If it's a peripheral tear, usually they heal in rapidly because it's well vascularized. And the literature shows that if you get anatomic reductions of the distal radius to the head of the ulna, and there's not massive instability, then you don't have to do anything. Very important, check the laxity of the other wrist before you start surgery. Because you get a young patient, a young girl with very lax distal joint, you might get mixed up and said, oh, and then, get upset about what you're finding here. So always check the real stability of the non-affected side.
Thank you, Professor.
Can I ask one question, sir?
Yes.
Yes. In the breech plating, do you make a 5 to 10 degree of a bend at the wrist dorsal bend to the plate, or you put a straight plate?
Straight, absolutely straight. If you do a dorsal bend, you want the bend, the whole distal metaphysis will shift into a dorsal and a central dorsal peel. So what you get with a bridge plate is usually a zero volar tilt. You don't get volar tilt, but you're in zero, which is acceptable. The comminution of these fractures dealing with bridging plate is massive. So it's a palliative type of treatment. We're not trying to get any anatomic reductions. What we have seen in the results published in the literature is that the results are not bad. X-ray doesn't look good, functions okay, and it's minimally invasive.
And the plate you use 2.7 screws in the metacarpals, or it's a 3.5 only? Because in the Indian bones, many times it's very difficult to put 3.5 screw with the metacarpal.
I would use, according to the size of the skeleton, like you do for a wrist arthrodesis, usually 2.7 for the metacarpal and 3.5 for the shaft.
Okay, thank you, sir.
Professor, one more question. What is your indication for primary bone grafting? When do you decide, does it require a bone graft? What?
When you have absolute bone loss, means that you have an open fracture that have lost bone. You have an open wound, comminution around the wrist, big wound, and some bone is gone. And then you have to.
What about the osteoporosis patient? In osteoporosis patients, we still tend to have some bone loss and bone defects.
Yes, in the massive osteoporotic patient, if you use locking plates, which are put very distally with the locking pins or the buttress pegs at the subchondral area, way distally, just underneath the subchondral area, most of the time you don't have. Even in oporotic patient, if you have the cortical shell around reduced with internal traction by the plate, then usually you don't need a bone graft. But if you think that it's too much, then you can use a bone substitute or bone graft. If you go in a osteoporotic patient to the iliac bone, you don't find anything. So most of the time, you might need to put some bone substitute. But it's not very often.
Okay, thank you. Prof, Dr. Murli, sir, you have any questions to ask? Prof, I just want to share one of our cases. So this is as you can see, this is a young patient with a fracture, like Barton fracture with volar subluxation. So this is as you said, it's a very difficult fracture to fix. Prof, do you recommend to get a CT in all patients of such fractures? What is the indication for a CT?
I've lived through all all the ways of doing it. When I was a resident, there was no CT scans. Then we used to use oblique x-rays to get more, exactly like for the acetabular fractures. You had to do oblique views or traction views. You can do a traction view, and sometimes you can, in traction views, you can see a little bit more information about how many fragments you have. But nowadays, if you can do a CT scan, it's the way to go, because as I showed you, the classification of Hintringer and all these classifications, the new one, are all CT based. So then you will find in the horizontal cut, which is the key fragment that displaces the carpus down. So then the tactics of the operation would be, go fix that fragment first, because then you're controlling the subluxation of the carpus. But this one here, 20 years ago, we had the same fracture. We went through the volar side, and it was a classic indication for a volar plate. It was actually the reverse Barton fracture.
Okay, Prof, I think actually it was fixed by one of our colleagues. So this is what happened. I think he's used a simple plate, and as you can see, the joint is still subluxed. So, Prof, you discussed about various plates, but unfortunately in here we don't have so many well-advanced plates to fix the hook. Do you recommend any tricks to fix this fracture without use of the advanced plates like a hook plate or whatever, volar lip plate?
Okay. Next time you invite me, I'll talk about this problem, because I have a whole talk on this. If you see this plate here is not well centered, and it should go over and cover the volar ulnar corner. There you can have a fragment that is very small, which is distal to the watershed line. If you don't catch that one, you won't control volar subluxation. So probably this is already the problem in this one. The surgeon didn't capture that, and then there's still some volar subluxation, but perhaps it's not an adequate reduction of and coverage with the plate. You're not buttressing it. If you don't have an implant that does that job, it means you have just a small volar plate and you're happy with the radial side, like in here, you can put a K-wire going in from the volar rim fragment, a K-wire, come up dorsally over here and fix and turn it a little bit, and you have that a very simple way of doing it. And you can also use a very small figure-of-8 tension band wiring for that, because it's a capsular attached fragment. There's also a paper by Jesse Jupiter with that. We wrote that a long time ago. Okay?
Okay.
So if you have the hook plates and all these things that we have in Europe and in the United States in the first world, it's okay. But if you don't have, there are a lot of ways of fixing that fragment. It's very simple. You have to recognize.
So actually, as you said, one of the techniques we use the K-wire from the volar side and got it dorsal. But still, I think the reduction was not up to the mark. As you can see, there's still some incongruity in the volar lip.
Well, this is already, at least you have now the carpus up in a normal and then if you leave it there for 6 weeks, you might have a residual acceptable incongruity volar, but the whole carpus will not dislocate back. Not bad.
I think here fragment was big, and it was a teardrop fragment which could have been fixed from the first day.
Yeah, exactly.
Teardrop fragment.
Yeah. Teardrop or volar ulnar, there are all these things. Teardrop is Dr. Madoff called it. Dr. Rob Madoff calls it.
Yeah.
Yeah.
You can take
Dr. Diego, there's a question from the participants. So asking how frequently you do brachioradialis stenotomy in volar plating.
Not very frequently, just when the intra-articular component of the fracture is irreducible and you have to have more place, or if it's a old fracture that you have a problem bringing it out to length. For example, an extra-articular Sumedh fracture, 3 weeks old, that you have to bring out to length. it's better to cut the brachioradialis because it's the only thing holding it down. You see? So and then you can suture it back to the periosteum. It's not a problem. But it's not very common for a simple extra-articular fracture, a Henry approach without all these release on the radial side is not necessary.
Thank you, Dr. Diego.
Okay.
Another question from me. Associated ulnar styloid fracture, in case of the instability at the distal radio-ulnar joint, how do you assess if it is because of the TFCC or sigmoid incongruity?
Okay, the thing is that the foveal attachment, it's at the base that actually extending a bit over the head of the ulna. So usually the fracture is to be very basal, and it has a little wedge that goes towards radially. That's where the foveal insertion is. If that's the case, that's the fracture that should be fixed if you have an unstable situation. If you don't have instability, as I said before, or acceptable ballotment, then you can also treat them conservatively. Just keep them 3 weeks in a sugar spin and slight supination. But if you want to fix, that's the only ones that you have to fix. All the other ones, a little bit higher up on the tip of the ulnar stylet, there's no real attachment that affects stability of the DRUG.
Okay, Professor, thank you. I think we are out of time. We need to go to the next talk. Prof, I would request you to stay put if you can for the other talks and share your valuable opinions.
Okay.
So many thanks for inviting me for this talk. Thanks to the Bangalore Orthopaedic Society and to Dr. Vamsi, who clearly has done very well with himself. I think we met many years ago when he was still a resident, and I think he's gone from strength to strength, and I'm delighted to see that. So today, I think what my remit is to speak on acute scaphoid fractures, primarily to look at the diagnostic conundrums surrounding it. Do all of these acute scaphoid fractures need fixing? What is the logic behind what we want to do in terms of proceeding with intervention, and when do we proceed with intervention? A little bit about surgical tips and tricks. I'd like to speak about the SWIFT trial and then end with a few issues regarding proximal pole fractures. So how big is the problem? About 8,000 fractures a year. These numbers are a little bit dated, and there's a definite seasonal variation, particularly in countries like Great Britain. The scaphoid bone itself is most frequently fractured within the wrist. We know that for a fact. The waist fractures are the most common, and it is the proximal fractures which create the most problems. So it's quite important that we don't miss these fractures in the first instance. So the mechanism of injury is very, very important. And these might sound like very basic things, but in the long term, when it comes to looking at your results and looking at what the patient needs, these are important issues which need to be looked at. So, if you have somebody who presents with an extreme dorsiflexion event, for any reason, it may be a fall backwards, or it could be a football or a forced dorsiflexion injury against a steering wheel, there's a high index of suspicion that that particular person has sustained a significant amount of trauma that could result in a fracture. So compare this against a relatively minor injury, and we need to keep this in mind when we make our diagnosis. Presence of anatomical snuff box tenderness and issues surrounding the various tests we'll come to later. We will look at various issues surrounding imaging, how we go about treating the fracture and review patients, and most importantly, the issues surrounding shared decision-making with the patient, because you enter this area of uncertainty, because with the best will in the world, with the best surgeon in the world, there are still cases where we don't manage to have a desired result. So let's look at the various clinical tests and see how good they are. I'd like to draw your attention to this figure on the right, 100% sensitivity and specificity if all these three tests are performed. Obviously, we've all in our clinical practices come in situations where this doesn't necessarily hold true. But it's fair to say that if these 3 tests were performed in all cases that we saw in suspected scaphoid fractures, the number of actual scaphoid fractures that we missed would become vanishingly rare. It's particularly important in Europe and in Britain because the legal profession has now got hold of these figures. It's part of published work from Joe Dias and his colleagues. And effectively, it becomes very difficult to defend a claim if these tests haven't been performed in triage, either in the emergency room or by the hand surgeon who sees the patient for the first time. We know for a fact that, in 85 to 90% of cases only, these fractures are positive for radiographs, which would mean that in 10 to 15 cases, you have this so-called occult situation or a clinical scaphoid fracture. And in these cases, it becomes very important to advise the patient appropriately, particularly as regards the chances of non-union, restrict their activity, stop their sports, put them in a removal sprint, and get them back in 2 to 3 weeks. And when you re-examine them, if they still have a reduction in range of movement, a second X-ray is performed. Now, there's been a lot of work that has been done at the time of the millennium, the year 2000, a little bit during 1980s and 90s, when MRIs were really coming into their own. And the pathway that lots of hospitals still follow is based on work that was done by Todd, dating back to nearly 1921. And it becomes quite clear very quickly that the pathway is a little bit dated, because effectively what you're trying to do is to treat 3 of every 4 patients who effectively undergo needless immobilization. And this definitely has the costs to the community. So the pathway really needs looking at. We had a national audit which was performed through the Royal College of Surgeons, and they looked at what happens in most of the emergency rooms and hand units and orthopedic units across Great Britain. And we found that the audit showed that only 6% of patients who actually underwent immobilization actually ended up with a confirmed fracture on MRI scanning. So a large number of individuals undergo unnecessary treatment and immobilization and second X-rays. Clearly, something that has changed the ball game, as it were, is the MRI scanning, and you can pick these up very quickly. The sensitivity of the procedure, as you can see on the right-hand side, is excellent. You need a good radiologist at the other end to pick up some of the more subtle changes. The other advantage is that if you find that you have other injuries within the wrist itself, these get picked up at the same time. So that is undeniably something that you can't go away from, which led NICE to come up with some of their guidelines specifically saying that, with scaphoid fractures, especially in situations where you have an element of doubt, an MR scan should be considered. Despite these articles and facts that we already know, a subsequent audit which was performed in 2019 across Britain showed that only 51% of trusts follow this advice. And this, to a large extent, even in the first world, as we call it, things become difficult because of the demands on the National Health Service and the absence of ready access and waiting times to MRI. In these cases, CT scans could be considered as a reasonable alternative. So in my view, in my opinion, these 5 X-rays, which I won't go into great detail because of time purposes, need to be done. You have the PA, the semi-pronated and the semi-supinated view, the true lateral view looking for any DZ or VZ type deformities, and the elongated scaphoid view, which you can see here. These are the basic minimum views that need to be done for the purposes of the procedure. A CT scan, a few tips and tricks about this, specifically the scan that you ask for needs to be a CT scan of the scaphoid, not necessarily a CT scan of the wrist. This needs to be made, this needs to be performed in the plane of the first metacarpal and the scaphoid itself. And there are various papers which show that performing these scans, it gives you a greater accuracy. However, a range of opinions is available, and to a large extent, a lot of these things tend to be operator dependent and dependent upon the type of radiological support that you also have. So just an example to show how these fractures can be picked up. So if the question is the scaphoid fractured? the modality, the investigation of choice would be an MR scan. If you want a little bit more information about how the scaphoid is fractured in terms of what the anatomy is, then you would prefer a CT scan. So if you have a particularly complicated situation, it is not unusual to perform both the MR and the CT, which some people might feel is over-investigating, but that tends to be the way of things, particularly in some of the more tertiary units. So we do know for a fact that displaced fractures do worse when it comes to the results. And what we're really looking for is a gap, the presence of a step, and the presence of any torsional issues or an angle or a humpback, which are slightly more difficult to identify. So effectively, the impact of the presence of displacement increases the relative risk of non-union to almost 4.4, which is significant because effectively what you end up with is a situation where you could end up with reduced movement and significant symptoms. So starting off with a fracture, which is something like this, you could probably treat this conservatively without any doubt in your mind. You end up with a gap which is getting a little bit bigger. You start thinking, is this displaced? Is this not displaced? And you may be tempted to do a CT scan in situations like this, particularly if there's a history, for example, of a significant fall. If there are other injuries that the patient has had, you would think about investigating this further. Maybe this is displaced. There is work which is unpublished, unfortunately, from the Pulvertaft unit in Derby, where Carlos Palu has a series of patients who have undergone simple radiological investigations like these, where for all intents and purposes the scaphoid was not displaced, but when CT scans were performed, there was a definite displacement on the scans themselves. So some of these can be deceptive. That is the lesson. So when you end up with a gap which is as big as this, probably 1 millimeter or more, tending towards 2 millimeter, you would think that this is a displaced and unstable situation. So you can see the difference of fracture that occurs on the 6th of the 8th, 2014. This was a chap who visited us from Australia. He turns up to us. By the time he turns up within a few days, flights, etc., you end up with a significant gap. And he was told in Australia that this fracture would be treated conservatively. Clearly, probably not the best decision. And we went ahead and fixed it with a reasonable result. But if something like that gets missed and you go to 6 and 12 and 18 weeks, the chances of the person developing a non-union increases. There is, I think, in my opinion, still a bit of a role for nuclear imaging. We don't do this very much in the UK anymore because of ready access to MR scanning. I personally find nuclear imaging difficult to read. But clearly, if MR scans are not available and if you don't have access to CT, this could definitely be an option. Coming to the exam question, really, should all scaphoid fractures be fixed? Clearly, these fractures need to be identified and quantified in terms of the presence of the criteria that we discussed. And despite insufficient evidence, there is an increasing tendency to immediately fix this fracture rather than to immobilize in a cast for 6 weeks and fix only those 10 to 12% that go on to unite. And the current trend to fix these fractures in many ways could be attributed to short-term benefits, but undoubtedly concerns still remain about the lack of evidence in terms of long-term benefits and additional risks from surgery such as malunion, infection, and related problems, including avascular necrosis. So we mustn't forget these issues, and certainly in Wrightington, what we use is something called as an aggressive non-operative algorithm. So once you've used an MR or a CT in the initial stage to make the diagnosis, on review, if the fracture is united or uniting, they go along a conservative pathway. If the fracture site is still seen between 2 to 4 weeks, you continue with assessment, splintage. We usually use below elbow plasters without including the thumb. And if at any stage we feel that union is not going according to plan, we consider treatment. So early treatment in terms of fixation, usually at the 12-week stage is considered in our institute. So between 8 to 12 weeks, if we find that the fracture is not uniting, we go ahead and fix these fractures. Obviously, if the person's occupation and it's an economic issue, an economic imperative, you would consider fixing this, and this would have to be discussed with the patient. And this is a dialogue that needs to be had between the patient and the surgeon. Usually, so if I'll go back there again, if the time since the fracture is more than a month, again, you would probably think about fixing the fracture. Proximal pole fractures, as a rule, get fixed in our institution, and displaced fractures for the reasons we've explained before. At surgery, some of the things that we need to look at and document very carefully would be the gap at the fracture site, any instability if you've identified at the level of the scapholunate joint, look at the vascularity, and look at the radioscaphoid joint for any degenerative changes. As regards Palmar versus dorsal approaches, I personally prefer the Palmar approach because you have a large scaphoid with a large tuberosity, you can identify a waist fracture, and the approach tends to be quite easy to and extendable if required. Dorsal approaches, for the proximal pole, these are quite straightforward. A lot of units, for example, if we were to go further south, for example, in Derby, a lot of the fractures, all the fractures get fixed, in fact, through the dorsal approach. So very quick video here looking at the procedure itself. You make your mark using lots of image intensifier control. This is a video from the Smith & Nephew unit. Put your guide wire through along the line, ensuring that you're screening right throughout. In the AP view, check in the lateral. And once the position is confirmed, you put a second guide wire for length measurements. And once you've confirmed your length, taken about 3 to 4 millimeters off for the cartilage, you put advance the wire into the radius to make sure that you don't pull it out, drill through, and then introduce the screw. So this is fairly straightforward. A note of caution, obviously, would be that it's important that in your mind you are very clear about how about the anatomy of the scaphoid, predominantly in terms of the position of the carpal scaphoid within the joint. You should have done a few open reductions of the scaphoid, a few dissections at least before you embark on this procedure, because otherwise this can be quite tricky. Just a few pearls and tips and tricks. Sounds like common sense, but very often you see trainees not using a towel. If you have a rolled up towel and you hyperextend the wrist in this position, it sort of elongates the scaphoid and makes things a lot easier. It's important to get a fixed point if you want to avoid going transtrapezially. You can use either a brown Venflon or a very wide gauge needle, and that really helps. The dorsal approach, use your dorsal landmarks, mainly the Lister's tubercle, follow it through, nice vertical incision, doesn't need to be very big. Retract your extensors to one side, the wrist extensors, and you're on the money. Important to dorsiflex the wrist significantly in order to ensure that you're in line with the first metacarpal. The second view just shows that very often what you have to do is to come from an angle if you want to fix these proximal poles so that you can go from pole to pole. What I mean by this is if you were to introduce your screw away from the scapholunate ligament and towards the fracture line, very often what happens is you end up with a cutout. So very often you have to come at a acute angle, and this can be a little bit tricky. As regards the Volar approach, we use the modified Garcia-Elias approach, which is based on the flexor carpi radialis. It's quite important to release the fascia that ties the flexor carpi radialis over the trapezium, because it's hard to very often get that flexor carpi radialis off adequately on the ulnar side, and becomes a bit of a struggle. So once you cut the sheath and identify the pronator quadratus, so you can use this particular procedure for taking bone graft out as well proximally. You use a ligament sparing procedure through the fibers of the radioscaphocapitate ligament, and you elevate these two flaps. So once this is done, you can bring these two flaps together and suture it together. It's quite important that we, things that occur very straightforward and simple on a cadaver or on paper are quite different when you do this in the real body. So this is the capsulotomy. When you actually do these for the first few times, it's quite tricky really to identify and expose the scaphoid and get these flaps open. A little bit of practice, and you don't really get that exposure every single time. But when it does work, you get a supreme exposure of the scaphoid, as you can see in this picture. This is actually a non-union, and you can see that we fixed that with a nice bone graft. So this is the sort of exposure you get, and you can close the capsule over the graft. So a little bit about the SWIFT trial, which is now concluded in in the UK, which was funded through the National Institute of Health Research. I'm sure all of you must have heard about some of the adverse publicity that the PROPFER trial had, particularly any trial that tells surgeons that they shouldn't operate is not usually received very kindly by the surgical fraternity. So the primary outcome was really looking at the PRWE, or the patient-related evaluation scores, and a host of secondary outcomes. And they found at the end of a year, 52 weeks, that there was very little statistical difference between the outcomes if the patients underwent urgent fixation of the fracture, or whether they treated it in plaster. And it becomes clear that the mode of initial treatment does not have a significant impact on fracture union, and clinicians should focus more on the impact of treatment choices on patients' day-to-day life. And the focus needs to be really on becoming normal again, more than anything else. So the aggressive protocol that we use, the algorithm that we use to step in with regular follow-ups in patients like this and fix them at an earlier stage is probably what needs to be done. Slightly different with proximal fold fractures. We know that the results are not great, and 34% will not unite if we treat them in a cast. The relative risk is nearly 7.5, and there's a stronger case for fixation. And we need to be clear about what these proximal fold fractures are. The ones that misbehave, and these usually are restricted to the proximal fifth of the scaphoid. We also need to consider the role of smoking, as well as people with Ehlers-Danlos and laxity. So that's essentially what I wanted to speak to you about, some of the salient features of acute scaphoid fractures. It's a very big topic, and I've tried to cover most of my experience, certainly since I was appointed at Wrightington. This is, as you know, one of our premier institutes within the UK, where the hip replacement was invented, and we'd love to welcome some of you there once all this COVID nonsense is over. It's a lovely place right in the middle of the countryside, just an hour's distance from the Lake District, and we hope to have you there at some point. Another little plug about our activities that we're doing currently with the supper with the upper limb unit. Essentially, we have these sessions every weekend on Sundays. They are mainly directed to individuals who are doing the FRCS auth exam, but increasingly we've had significant attendances from hands experts and consultants. Hopefully, if you can register, this is something that you can attend. We are doing the rheumatoid hand and the wrist next. Thank you. That's me done.
Okay. Thank you, sir, for the wonderful talk, what you have given. And I have a question, sir, for you. Sir, how often do you see the scaphoid fractures with associated distal radius?
You've been in an acute situation?
Yes, sir.
Yeah. So if you have, so it's not that uncommon an event. You know, you do get fracture scaphoids with distal radius fractures. And my temptation is to essentially fix all those scaphoid fractures, even if they are undisplaced, so you know it doesn't really interfere with the post-op immobilization. You can use the Volar approach, just extend it more proximally with a hockey stick, like I've described, and go ahead and fix that. The other option is to fix the distal radius volarly and address the back of the wrist through the dorsal approach. That gives you the opportunity to look at the scapholunate ligament, eyeball that ligament, and treat any scapholunate injuries at the same time. The other thing that we do on a regular basis is to scope these. So we look at a lot of these in arthroscopically for the purposes of finding out whether there are any associated TFCC injuries, whether there are any osteochondral lesions, and address them at the same time. So we do a dry scope. Arthrex has now come up with a nanoscope, which is a very thin tube, and you can really slide that in and out quite easily with minimum amount of traction. So that's another thing that we've started doing at Wrightington.
Dr. Sumedh, I have a question.
Yeah.
So like you said, for the surgical interference in the waist fractures, by having planned for the conservative management would be between 6 to 12 weeks. So would you consider bone grafting at this time?
Yeah. So that's a very good question. So if you are towards the 8-week stage and you find that the gap is not enormous and you have adequate bleeding from both ends of the bone in a non-smoker, someone who's does not have elder loss, who's a relatively young person who's fit and healthy, I would consider not bone grafting it. If you were in a situation where there was a lot of fibrosis and you were towards the 12-week stage, I would consider that, it's just best to do one surgery, bone graft it, put some graft there and fix it at that point in time. So that is my decision making.
Dr. Sumedh, there is a question from the audience. Dr. Rajiv Nayak wants to know, in your practice, what percentage of fractures do you fix?
So acute fractures, we fix very, very few. I would say probably one a month, considering the fact that we see about, as a unit, we see about 20 to 30 a month. Very, very few of the scaphoid fractures get fixed acutely. It's very important to know that particularly for surgeons who are embarking on this for the first or second, at an early stage in your career, that a truly displaced scaphoid fracture is very difficult to fix anatomically in the presence of comminution. So I would recommend that you get this looked at by a good hand surgeon. If you're doing it for the first time, make sure that you have help when you try and fix these together, and don't try to do these on your own, because you can end up with lots of problems from where it is difficult to retrieve the situation.
Thank you, sir. I think we'll move on to the next talk. And please stay on, sir, so that we can take the calls after the scaphoid non-union. Next talk is on scaphoid non-union. The speaker is Dr. Bharat Kadadi. And I am very much overwhelmed to introduce him to the session. He is actually the first person to hold the hand surgeon beacon in Bangalore. And he has done his MBBS from MMC Mysore from 93 batch. And then he continued to do his MS Ortho from JJM Davangere in 98. And he has done fellowship in hand surgery from Stanley Medical College in 2003. And then went on to pursue his quest in brachial plexus fellowship from Japan. As of now, he has conducted many hand, wrist, and brachial plexus workshop from last 15 years. And he's also has got many international presentations and publications under his belt. So here I would like to ask Dr. Bharat Kadadi to continue his talk on scaphoid non-union. So please.
Thank you, Kishan. Can you hear me?
Yes, sir. Wide and clear, sir.
Thank you. Is my screen on?
Yes, the screen is on, sir. We can see.
Yeah. Hi all. Thank you, Sumedh Talwalkar, for making my job easy. Well, scaphoid non-union and avascular necrosis, I'm sure all of you would appreciate the need to treat these scaphoid non-unions much more when you see a patient who's presented with a neglected scaphoid non-union for over 1.5 decades. You can see that established non-union with the early arthritis of the wrist called a snack wrist, scaphoid non-union advanced collapse. And there's so much pain that the whole wrist is hurting. Goes on to reinforce the paper from Leonard K. Ruby et al., who clearly concluded that scaphoid non-unions should be advised that osteoarthritis will most likely develop. 97% of the patients in this series were untreated scaphoids. We followed up and seen them that 97% developed osteoarthritis, and that's the importance of treating scaphoid non-union, either symptomatic or asymptomatic. Going on further, the quantitative meta-analysis of literature, you see, for unstable non-unions, a screw fixation with grafting gives 94% union, superior to K-wires and wedge grafting. And whenever there is a avascular necrosis of either the proximal or the distal fragment, vascularized bone graft had a union rate of 88% versus 47% compared to the screw and wedge graft. But now I would like to bring all your attention to intricacy of this scaphoid, a particular intricacy we call the interscaphoid angle, where the scaphoid scaphoid has curved itself in an interscaphoid angle in the coronal and the sagittal planes. So that's what it's called a twisted peanut, and that's why it's complex to get into the central axis of the scaphoid to fix this one. Going further, if you see the natural tendency of the scaphoid is it's volarly flexed. So whenever there is a fracture, the distal fragment flexes and the proximal fragment extends, leading to what you call a DC deformity because there is an increase in the scapholunate angle. So basically, what you call a scaphoid humpback deformity, where you get volar shortening of the scaphoid, angle in the apex dorsal and the dorsal shift leading to DC, which is very much appreciated in the CT scan pictures here. Well, is it important to correct the DC deformity? You can see it's very, very crucial to correct the DC deformity when you address these non-unions, because you need to avoid the kinetic problem that can lead to arthritic changes, and a CT scan will be able to appreciate your personality with the non-union better. In addition to the important clinical and X-ray features, which already Sumedh has mentioned, the indication for an MRI is basically to look for avascular necrosis of the proximal and the distal fragments, and to look for the other associated wrist ligament injuries, and also to look for development of arthritis, that is the radiocarpal and intercarpal arthritis in the wrist for neglected non-unions. Well, the purpose of the CT scan is look at the personality of the fracture, the non-union, as you can see here, the reflection and the fracture and the humpback deformity, and to plan your surgery to know how much wedge of grafting you'll be needing to correct the annulation and the length of the scaphoid. When you embark on the journey of treatment of these scaphoid non-unions, it's very important to know the risk factors, because unless you address these risk factors, your this definitely have a problem. And then the non-unions 10 to 15% in treated fractures, whereas the non-union goes up to 40% in untreated fractures. So one is the delay of presentation and the proximal pole fractures, as you all know, because of the poor vascularity, they are prone for non-unions. And whenever there is a fracture displacement at the initial setting, they more than 1 to 2 millimeter of displacement, and particularly with the DC deformity, and they are even prone for the risk for non-union. And if they're associated with the avascular necrosis of the fragment, and as I already mentioned, that the smoking could be directly proportional to non-union, just like any other non-union. So it's important to address these factors when you contemplate treatment of these scaphoid non-unions. Now here is a patient with scaphoid fracture non-union. As you can appreciate, the humpback deformity in the sagittal views. And MRI of this patient always shows there is good vascularity with both the proximal and distal fragments. You can see the reasonably good signal, there's no signal changes, it's isometric to the other bones. Now, the plan is to do a volar wedge, intercalary wedge grafting with a volar approach, as all of you will be able to look here with the inverted hockey stick incision along the FCR tendon, make an incision. As you do that, go along the roof of the FCR, and then for convenience, you might either retract the FCR radially or ulnarly, depending on the approach to the variations in the anatomy of the distal pole of the distal fragment of the scaphoid. Then start working around the tubercle of the scaphoid. You retracted the FCR tendon laterally. As you go through, you divide the fascia and go to the deeper aspect, and then you are able to appreciate the working on the distal pole of the scaphoid, both radially as well as ulnarly, and that's the radioscaphocapitate ligament. It's important to identify this ligament. Fractures which are distal to this ligament, like a tubercle fracture, can be treated without dividing the ligament, whereas fractures at the waist and proximal to this waist we need to divide the ligament and to resuture it back again. So once you start working around the non-union site, go around and carefully dissect the tissues both medially and laterally, and that's your non-union curated well, just as the secret of a treatment of any other non-unions. And that you have the proximal and the distal fragments curated well and kept ready, and make sure that your good cancellous bone is exposed. Now you proceed proximally to expose the pronotic quadratus at the attachment of the radial styloid. You elevate the pronotic quadratus from the radial styloid, and then you already marked your CT or made a calculation of what is the kind of wedge graft you require. It's normally a trapezoidal wedge. As you can see there, the marking of the wedge graft done in the distal radius, make holes with the KOR, and then you find orchotome to elevate the graft. And that's the trapezoidal graft required to wedge it in between the proximal and the distal folds of the scaphoid. And you also take some cancellous bone to pack in gaps. And many times you can have cystic changes where you need to pack in good cancellous bone graft to build the gap. And that's where the graft is placed between the proximal and the distal poles. Often it fits like a press fit. And then you use the regular technique where you pass the guide wire distal proximally. The second guide wire along the axis of the scaphoid. Once you confirm that the guide wires in, one is to hold the fracture, the other is to get your screws through the axis. And then most of you must have used this device, the compression device, or the headless compression screw. And as already mentioned, that the measurement should be usually 2 + 2, 4 mm less than the length of the scaphoid, because you need to bury the screw well inside. As 80% of the scaphoid is articular, you can't afford to take any chance of being screw long, so it's good to have a good size of the screw. And then there's a good stability of both the fragment fixation of scaphoid. And then it's very important to close the radio scaphocapitate ligament. That will be your post-op picture. Follow up at 2 years. Now here is the patient, 35-year-old male present with a bike accident 4 months back. So his initial X-rays has which the fracture scaphoid has already emphasized that it's very, very important to take the special views of the scaphoid, the PA view, the PA with the ulnar deviation, the pronation oblique view, and the true lateral view. And this patient will be able to appreciate the scaphoid fracture bilaterally in the pronation oblique view and the PA view with the ulnar deviation. So because it's already 4 months going for a non-union, so we have to take up the right side first. A software professional. So in the arthroscopy, this is in the wrist traction tower where you suspend the wrist in the traction under regional block. Most often when you, and what basically the scaphoid fracture are best appreciated in the mid-carpal arthroscopy, where the scope is in the radial mid-carpal portal, whereas your shaver is in the mid-carpal ulnar portal. As you appreciate the fracture, the gap, and then these patients normally are not under any tourniquet. We don't inflate, although the tourniquets are tight, we don't inflate the tourniquet. So the advantage is once you debride the ends, you'll be able to look at the bleeding from the fracture ends, both the proximal and distal pore. So once you've done that, you can always pass in a guide wire, as you can see in the figure in the right. Get your guide wires right in place, and then pass in the cover screw distal proximally, will bury the scaphoid, and make sure that it is perfectly well seated with a fluoroscopic vision. You can see that. So the next question is, does anyone need a vascularized graft? Well, if you look at this paper, May 2012, those fractures which fail to unite are likely to develop avascular necrosis and a progressive structural collapse. So, vascularized bone graft has been demonstrated utility in promoting consolidation in the treatment of scaphoid non-unions, which are complicated by avascular necrosis. Going further, what are the indications of vascularized bone graft for scaphoid non-union? Only those scaphoid non-unions which have avascular necrosis, which can be ideally be identified by a MRI scan taken preoperatively, and better identified on the table. You see the revascularity on the table of the fragments, the proximal fragment in particular. So previously failed surgery, you wouldn't want to take a risk. You would prefer to do a vascular bone graft, and those proximal bone non-unions always prefer to do a vascular bone graft because the risk of non-union and AVN is much higher. The smaller the fragment, the risk is higher. And what are the possible vascular bone grafts you have? On the dorsal aspect, you can choose the 1-2 intercompartmental suprarenal artery, the 2-3 intercompartmental artery, or the base of the second metacarpal artery. And on the volar aspect, you have a choice of looking at the volar carpal artery, the branch of the radial artery, which anastomosis branch of the ulnar artery at the ulnar corner of the radius, and also used to do a muscle pedicle graft, parental quadratus graft. So here is the patient, medical student presented 7 months later with a scaphoid fracture non-union. As you can see, this comes comminution 2 in the CT scan. MRI revealed avascular necrosis of the proximal fragment, which you can see the signal changes. You'll be able to appreciate well here these images. So let's go and see how you do. It's called the Zeidenberg flap. That is the 1-2 supraretinal artery, 1-2 intercompartmental supraretinal artery flap. Basically, the incision is centered. L is for Lister's tubercle. The incision is centered around the Lister's tubercle along the EPL tendon. So as you go ahead and incise the skin, and you raise the flaps, as you can see there, it's very important to do not exsanguinate the limb. Just elevation of 3 to 4 minutes is more than enough so that you will be able to identify the blood vessel well. It's a recurrent branch from the radial artery. There is a superficial vein which is obscuring your vision. So you can always use the bipolar cautery to take it out of the way. And that's the recurrent branch of the artery. So on the radial side, you have on the ulnar side, you have the second compartment borne by the ECRL and ECRB, and on the ulnar side, you have the first compartment with the APL and the EPB tendon. So you divide the sheath of the second compartment and include your vessel within that and retract the tendons radially. As you do that, and you also incise the sheath on the first extensor compartment, and by retracting the first extensor compartment tendons radially. As you do that, you'll be able to do and that's the proximal area of vessel where you ligate it so that you can, and that's the place where the nutrient diagrammatically ligated, and that's the area where you have nutrient artery entering the distal radius. So once you've done that, you can divide the vessel. It's based on the distal proximity the supply from the recurrent branch of the radial artery, as you can see here. And then you mark your bone graft required with the K-wires on either side, both radial and ulnar aspect of the pedicle. Use a fine astratome, and you need to elevate. That's the bone graft along with the pedicle and the periosteum. You take it as distally as possible. You need to have a good length so that you be able to put a scaphoid, and then between the third and the fourth extensor compartment in the wrist, you open up the capsule with the transverse incision and expose the scaphoid fracture, as you can see there. Curate it well. That's the secret of treatment of many non-unions. A good cancerous bone exposed there, and then you fix the scaphoid with the already described with the guide wire and the anti-rotation wire and the Herbert screw, the headless cancer couple screw, and that's the vascular bone graft based distally. When you realize that the length may not be important to reach your fracture site, you can further extend good to the tip of the radial styloid. Make sure that, and that's how you deliver the graft, by extending the wrist so that your extensor tendons are relaxed, and that's the ECRL and ECRB. So you deliver the graft under the ECRL, ECRB to the site of the fracture, place it there, and K-wire. K-wire is just to hold the fracture, because already you secured the onion with the compression screw. It's just to give the vascularity at the site of the fracture. And this is how the post-op image looks. So it's important when you elevate a vascular bone graft to the flap, it's important to look for the bleeding. You can release the tunicate, you can give some saline, and also look for the punctate, the bleeding punctate spots on the vascular bone graft. So 6 weeks of short thumb Baker cast and then physio for the wrist and thumb mobilization. At the end of 1 year, that could be the result. So on the Volar aspect, you have what you call the Methol has done a lot of work on this, where he's selected the volar pedicle artery with the distal radius graft for the which non-unions. A report of 111 cases. He's given a union rate of 96% and 89%, 96% in non-union, 89% in avascular necrosis. And then here is a patient who has Scaphoid non-union of the waist, and you can be able to appreciate in the CT scan the cystic changes and the frank non-union with avascularity of both the proximal and the distal fragments. So we plan hockey stick incision. Just in short, just to show the volar pedicle is the radial aspect. You get the orientation right, and this is the vessel rises from the branch of the radial artery, goes along the distal margin of the radius, just distal to the pronotum quadratus. You'll be able to appreciate here. So that's the branch of the radial artery. That's the distal radius. And then you, as and when you identify the amount of graft required with the depth, the breadth, and then elevate the graft at the distal radius, distal ulnar collar of the distal radius. Just a couple of slides, and then you export the fracture site, non-union, cured it well, and kept it ready. And then you have the graft which can move adequately to reach the Scaphoid non-union. That's how you fix the graft with the distal proximal headless compression screw, and the wire is just to hold the vascular graft in place. So with the experience of treating several hundreds of scaphoids over nearly 2 decades, with this protocol suits well, particularly when there is a gap of 1 to 1 millimeter. I would prefer arthroscopic assisted reduction and a fixation. Whenever the cystic changes, you do a bone graft with a Hubbard screw. Whenever there is a humpback deformity, you got to correct the humpback by do a volar wedge grafting and then use a Hubbard screw. Whenever there is a avascular necrosis of the distal or the proximal or both, then do a vascular bone graft and fix it well with a Hubbard screw. Sometimes whenever there is a proximal pore is very small, you will not be able to fix. Then you can always use a K-wire when you use a vascular bone graft, but immobilized to 8 to 10 weeks till the fracture union. And whenever the AVN of the proximal pole and the proximal pole is very small, so you can excise the fragment because there can be carpal instability. You can do what you call a scaphocapitate fusion. And when you have a non-union with osteoarthritis, early osteoarthritis changes, SNAC 1 or SNAC 2, you can always go and do a radial styloidectomy because the arthritis is restricted to only the radial aspect between the stylo, scapho region. So you can do a radial styloidectomy and put in a Hubbard screw and a bone graft, and then they do extremely well. You can halt the progression or slow down the progression of osteoarthritis and leave the salvage procedures for a later date to come. So a small bone, large stake. It's very, very important to not to miss these fractures. And so you have a protocol of checking the good clinical as well as the good X-rays, and then follow the protocol which will help to prevent the non-union as well as to treat the non-union. And whenever in doubt, always seek opinion from your colleagues, from experts. You can ask to what to do in a particular fracture, because a mind open to alternative perceptions is a mind aligned with love. Thank you. Thank you, Anand.
Yeah. Thank you, Dr. Bharat. Compliment you for that nice, elaborate presentation. I have a question about Dr. Sumedh and for Dr. Bharat. We have a lot of people asking what would be the correct position of a scaphoid cast?
Bharat, you want to go first?
Go ahead, Sumedh, please.
All right. So, I mean, for us, we've traditionally not used the thumb. We just put a below elbow cast, and it served us well over the years. I think it was only very early in my training in the UK where we did use the thumb, but that very quickly fell out of favor with Joe Dias's paper. So the thumb isn't used. It's placed in neutral, just a simple below elbow cast without involving the thumb.
And how long do you keep the cast on?
Between 6 to 8 weeks, that's our minimum immobilization. We usually follow people up at 2 weeks, 4 weeks, and 8 weeks. At the 8-week stage, if we find that things are not going according to plan, patient usually undergoes a CT scan, then the conversation regarding surgery is first broached. I mean, we keep that in the back burner right from the beginning, and then consider intervention at that stage. And sooner rather than later, we'll go ahead and fix that. And given those parameters regarding the risk factors, we will decide whether to bone graft or not. One of the things we've increasingly started doing is in these, those gray non-unions like Bharat does, we've started doing a lot of arthroscopic work. We bone graft them using, the tube that comes with the reamer.
The cannula.
Yeah, the cannula. The tube that comes on the cannula, we cut that in a V shape. So that's easy to introduce. So you take that, once you've cleared the non-union, you introduce that tube into that area and inject the graft through the tube. So by the time you've done all your interventions and everything, you can get that graft in nicely into that gap. Otherwise, delivery becomes a problem. You always start off dry arthroscopy, and then as the will to live becomes less and less as time goes on, everyone is getting a little bit restless. So it's important that the most important step, which is the bone grafting and the introduction of the screw, you give enough time for. So I think it's important that at that stage, everyone's concentration is focused at that point. So I'm glad you showed that bit arthroscopically.
Yeah, and the point here, I have been using the short thumb spica cast for 6 to 8 weeks because they would like to immobilize thumb, because our patients, they can start riding bikes and they can use the hand recklessly. So once you immobilize the thumb, they will not be there. Their usage is grossly restricted. So I would prefer doing the thumb spica cast. Yeah. Although there is literature stating that there is no real difference between the two, I have been using the thumb spica cast.
Can I just come in? It's very important, we do all these things to our patients when we put people into casts with the thumb involved, like what Bharat said. It might be useful for some of the orthopedic surgeons to spend some time in a cast involving the thumb to show how restrictive that is really in their everyday working life. So it makes a very big difference not having the thumb involved.
Any advantage of getting the thumb in?
None at all.
None at all. And can you have a small words on your innovation of plating the scaphoid, Sumedh?
Well, that's a separate talk, as you well know.
Yeah, I know.
So we reserve.
So because there is a controversy about fixing by the screw, K-wire, and the plate. Yeah. Even in the non-union, some surgeons prefer K-wire only. They don't prefer screws.
Yeah. So that's absolutely fine. So what my take on this is that if a K-wire is used adequately and properly, there is nothing wrong with using a K-wire, whether you use it for the distal radius or you use it for the scaphoid. There's absolutely nothing wrong. It's the awareness of the anatomy, the way you treat the fracture site, the adequate bone grafting, making sure that the wires are introduced underneath the skin. Wires only become loose when they get infected. So if you use wires which have adequate purchase in both the fragments and they're well held, there's absolutely no issue. We see so many complications with screws, particularly the SWIFT trial. They found issues surrounding patients who had long screws. It's like a coconut grater. Effectively you have that little bit of a spiral screw which comes out through the dorsum and it grates the dorsum of the radius. So that is a disaster. So remember, these are big weapons of mass destruction, if I might use the term. So then when you come to the plate, you need that sort of exposure that I showed you, where you're looking at the scaphoid end on. You need to be able to place the plate so that you've got at least 3 screws proximally and 3 screws distally, and the screws need to diverge in a particular format, so that they're fixed and they're contoured. The important thing that once the plate is in is that the proximal part of the plate should not impinge on the volar lip of the radius, because if it does that, you get that noise when they volarly flex. So that can be a major problem. So the plate is only used in situations where we have implant failure in a non-union situation. What we found in our hands in Wrightington is that we don't do well with vascularized grafts. As a unit, we published our results with this Heidenberg graph. We only had a 50% rate of union. So as a surgeon, as a unit, you need to know what you're good at. And once you know what you're good at, then you can focus your attention and your abilities on developing alternative skills or using implants which work for you. So we've gone the plating way, but someone who's highly skilled like Bharat, clearly, you know, with his wonderful pictures that he showed us, you know, you could probably get away with doing more vascularized work. So we don't have those numbers to cover us. You know, 96% or 100% union rates like Heidenberg quoted. We were not able to replicate that. So we use alternative methods.
So those who want to see in detail about plating, Dr. Sumedh has already described in Geo webinar of Scaphoid, the grand webinar of only on Scaphoid.
Yeah, I remember Dr. Naveen. I
Yeah.
think.
Yeah. So he had described very well. So just a reference.
Thank you.
Dr. Bharat, I have a question for you. And I think probably before that, Sumedh, I think you would like to continue the thing, or heard that you would like to leave.
Dr. Fernandez had something to say. He had raised the finger previously.
Yeah, I wanted to ask if he knows the protocol of Tim Davis that used to take the cast off out of 4 weeks after the fracture and did, I think, was CTs or MRIs.
Yeah.
Already at 4 weeks, and I thought it was too short.
Yeah.
What happened to that protocol? Do you
So
remember?
we stopped doing that fairly quickly because Tim did not publish the results. For whatever reason, that particular aspect, Tim, as you know, Prof. Davis publishes almost all his work, but that particular bit did not ever get published. And 4 weeks, I fully agree with you, is far too soon for the scaphoid. It's very risky. So I would probably use the 4 week stage for that sort of contact with the patient to let him know things are going well or things are going badly and we might to intervene. So it's all about managing expectations, isn't it? So that's the 4 week appointment. That's what the 4 week appointment is for. But it is definitely not to take the plaster off and get people to mobilize. That's not the purpose of that visit.
So I always left the cast. I always left the cast for 8 weeks.
Yeah, minimum.
8.
Minimum 8 weeks. And if
then,
required, I tell them that you've lost 3 months of your life. So, think about 12 weeks, write them off.
Exactly.
Actually, I have got one question. This is for all 3 speakers, including Professor Diago. Sir, I want to know, when do you want to operate in an asymptomatic non-union? Because here we sometimes get, when they come for other injuries, we incidentally find there is a non-union. And when do you think you need to intervene in these cases?
I found that I found this asymptomatic non-unions, mostly those of the proximal pole. See, they're not the ones that produce a humpback deformity, but a little bit more proximal. The carpal alignment remains perfectly well and there's no collapse. And if there's not an avascular necrosis, this works like a separate carpal bone. So I don't think you have to go and treat something that is asymptomatic. You don't go to the dentist if you don't hurt in a tooth. So, but if I see that's the deformity or a beginning carpal collapse or an osteophyte on the styloid, like a beginning, like a slack 1, then I would do a styloidectomy and fix it because there's a progressive deformity that might end up in the snack wrist.
Yes, I think this term asymptomatic is a word hanging between time and tide. Today a person who is asymptomatic may be symptomatic tomorrow. So when you know that the literature says that those untreated non-unions can definitely go in for osteoarthritis, so it's always good to advise the patient that it has to be dealt with.
Bharat, I have a question for you.
Yes,
participant. What can be done to minimize kinking of the artery and vascularized graft?
Yes. You look at the line of the vessel. Suppose you're taking these Heidenberg flaps, make sure that it's in the same line. Don't rotate it more than 60 to 90 degrees. So you can just rotate it, but make sure that it doesn't kink. And of course, you need a good assistant to help you out with that. When you do that, and then you can mobilize the pedicle in such a way that whatever structures are preventing your mobilization, you can just slowly release them. Try and take the periosteum along with the pedicle so that you don't injure the pedicle. There is a good cuff of soft tissue around the pedicle. It's important to take they might have mentioned that dividing the sheath in the first extensor and the second extensor compartment so that you can take it along with that. Yes, Diego Fernandez.
I found that when I was doing the Seidenberg, that if you do a little small styloidectomy, sometimes you get a little bit more place to fit it in, especially if it's not very proximal non-union, but most on the waist, you have to a little bit more distally. Then a styloidectomy helps you get more place and the pedicle is not under tension.
Sir, I want Dr. Sumedh also to comment on the non-union.
Yeah, so I had recently, it's a very good question. I had about 3 cases that came one after the other very recently, where you had people who had asymptomatic non-unions who had been referred to me from other surgeons. And they were asymptomatic to the extent that people were performing push-ups, they were taking part in sports, and they were all young people. So clearly we are in a situation, it's a medical legal environment, unfortunately, in the rest of the world, where you have to make these decisions. And if you are going to be the last word, you have to make sure that you have adequate protection. So one of the things that I did was to run it past our MDT. And I asked Joe Dias and I spoke to Mark Garcia-Elias about what their take would be. Now, we had 2 different opinions. Now, Mark was very clearly on the side of Dr. Fernandez. He was very clear that in situations where you don't have a problem, please don't try and fix it. You know, there isn't a problem there. Clearly, these people are asymptomatic. I know there is a fracture. Don't get fixated on this. Leave him well alone. Keep him on a follow-up. If a problem does occur, you know, intervene at some point. Obviously, as you go further and further away from the non-union, the index event, it becomes more difficult. So, for example, you have a 10-year-old non-union in someone. If the person is 20 and he's had this fracture from the age of 10, the likelihood that my intervention is going to make that scaphoid unite is very, very less, because that has sort of, the body has arranged itself around the wrist. And the likelihood that he is asymptomatic is because he's got a type 2 wrist. So you know what a type 1 wrist and a type 2 wrist is. A type 2 wrist has a second sort of articulation to the hamate. Because of that, those wrists are inherently stable. And more often than not, if you go back and look at these radiographs, you will see that these are stable wrists. So I would probably err on that side. And when I spoke to Joe, they're about to come up with a paper which says that these asymptomatic fractures should all be fixed. Now, in this particular case, luckily I was saved by COVID, because I didn't have to make that decision. But going back now that we are going back to work, we are going to have to decide what to do with these guys. We've got about 2 or 3 people who are waiting for this decision. And my intention is to fix 2 of them who are completely asymptomatic. And there's 1 individual who's very proximal pole, like Dr. Fernandez said, and that chap might need to be fixed. So that is my take on it. I could be wrong. There is no published work, but we are waiting for the work to come out from Nottingham, from Leicester.
Thank you so much, sir. I think we are running out of time. It was a wonderful session.
Sir wants to ask Dr. Uday Kumar.
Yeah, you can. In cases of symptomatic bipartite scaphoid, does it require any attention or do you just leave them alone? Symptomatic bipartite scaphoid, a question from the audience.
So you mean a congenital segmentation of a scaphoid? You know, you got
exactly. But
I mean, any case where there's been a congenital issue of the wrist, whenever. So I've inherited a few cases from my predecessor, Professor Stanley. You know, wherever we have intervened with nature, we have come unstuck very quickly. So the end result is always a wrist fusion, I feel. So I would suggest that, you know, do not interfere. Any form of these issues, give a wrist injection, just treat conservatively, just speak nicely to them, and that's it. That's what I feel.
Absolutely.
That's correct, yes. Yeah. Thank you very much. And
I'm really sorry. I'm going to have to leave if that's okay. But it was a great session, and many thanks for inviting me.
Thank you, Dr. Sumedh, for that excellent involvement.
Thank you.
Yes.
Yes.
thank you very much.
Dr. Sumedh, bye. Thank you.
Bye, Naveen. Thank you. Nice to see you again.
Yeah.
Thank you.
President Madan Vamsi for this opportunity. Yes, Kishan.
Yeah, we thank Dr. Bharat, Dr. Diego, and Dr. Sumedh for a wonderful session. My name is Dr. Kannan, one of the moderators for the next session. I'm here to introduce Dr. Keiji Fujio. I'm very happy to welcome him to our webinar. He is probably pretty late in the night for him, and we are grateful that he has joined us from all the way from Japan. A little bit of an introduction about him. He finished his, he's currently the general manager of Osaka Maki Orthopaedic Hospital from 2020. He also holds the position of a clinical professor at Kyoto University. He finished his medical school in 1985 and finished his residency in 1995. He also did a fellowship in hand surgery in the Carroll Hand Center in the US in 2009. So his main interests are wrist surgery. His research interest is wrist surgery, arthroscopy, and TFCC surgery. Without further much ado, let me welcome Dr. Keiji Fujio, if I'm pronouncing it right. I apologize for if I'm not doing so. Please, sir, take over and please enlighten us on the methods of open to arthroscopic TFCC repair. Thank you.
COI. Can you hear?
We can hear you loud and clear. We can hear you loud and clear, sir. Please go ahead.
We usually use this type of wrist support during 3 months after injury. This MRI shows dorsal subluxation is reduced with this support. The literature about conservative treatment for acute TFCC injuries were very few. This report is from Japan. A prospective study reviews conservative treatment with wrist support is effective for 70% of patients. We also review the prospective case study for 23 cases of TFCC foveal injury. According to our results, about 60% of conservative treatment was effective. Young patient and severe DRG instability and high quick dash score was a factor of necessary for surgery. And athlete is recommended surgery rather than conservative. A TFCC is like a hammock structure. The TFCC separates the RCJ and the DRJ. And the proximal component, or so-called the deep lateral ulnar ligament, is the most important for the DRJ instability. It is inserted as the ulnar styloid base called ulnar fovea. Palmar's classification is famous. Although this classification is simple, but it is confusing that 1B includes a foveal detachment and the peripheral tear. As you know, TFCC foveal attachment is most important role of DRG stability during rotation. In severe case, a bone side is subluxed dorsally. So sometimes the location of avulsion is displaced between bone side and the TFCC side. Open method from dorsal is necessary to incise ECU's sheath and the capsule. A direct vision to fovea is easy to access, but pathology is not clear. ECU irritation after operations open surgery is serious problem. Now joint surgery is developing to arthroscopic surgery. There are several techniques for arthroscopic technique. Regarding transossal suture, a few reports about inside-out technique was found in English literature, except for Chris technique using meniscus repair kit. Today, I would like to talk about my favorite inside-out technique. I prefer to use spider system for traction system. It is convenient for holding on the wrist, posture, spination, neutral, and pronation. We use curved single lumen guide passing wire with sutureless, which is flexible wire with loop, a suture tape woven by fiber wire, and a curette for debridement. We use mainly shaver, sometimes forceps and RF system. We do usually 3 steps procedure: a diagnosis, a debridement, and a suture. And nowadays, the Arthroscopic technique is developed, and using the technique to inflate DRUJ with saline and expand DRUJ space with curved mosquito. So we can find out foveal tear and the quality of stump. Are there any scar or a real ligament? As you know, normal deep portion is like left slide. From DRUJ scope, right slide shows a rupture of Volar deep portion. A trampoline sign is dependent on the examiner's experience and ambiguous for diagnosis. Hook test is one of the reliable tests for foveal tear. In my personal opinion, floating sign features a sign. A TFCC around the fovea is floating during suction with shaver is usually helpful to make decision of foveal detachment from larger carpal joint if there is no connection between the RCJ and the DLJ like 1A. After reattachment, there is no hook test, positive, and no floating around fovea from RCJ view. A second step is foveal debridement. It's very important. This slide is courtesy by Professor Atse. A debridement group can get better results, especially on the subject, pain, and the DRJ instability. From larger DRJ portal, scope is introduced and the probing from ulnar DRJ portal. A debridement was performed from ulnar DRJ portal. Sometimes you feel busy to manage because scope and shaver is very close. It is impossible to manage from dorsal side. Shaver is inserted from Volar fovea using switchback technique. The maneuver is more easy. If you feel difficult, you'd better to open the direct fovea and debride directly using curette. Third step is foveal attachment. Since 1999, we have operated with insider suture technique for foveal injury of TFCC positively, and the technique is modified. So I'd like to introduce our technique and its result. A passing wire, which has a loop at the end of the needle, is drilled via the curved guide through the ulnar TFCC and the distal ulnar bone, and comes out on the ulnar aspect of the distal ulnar cortex. Then a suture tape made by fiber wires runs through the hole, and the passing wire is pulled from the distal ulnar. Usually knots are placed around the isometric point. A suture tape woven by fiber wires runs through the hole, and the passing wire is pulled from the distal ulnar. Assistant should hold the wire with plier and pulling with a hammer gradually like this. A fiber tape is anchored with 3-block system, just proximal as a hole pulling out the tape. A suture site is not bulky and no irritation for skin. And where should we decide as isometric point from radiocarpal joint? So we examined isometric point plotting defined point each TFCC and fovea using cadaver, and measured the displacement of during spination and pronation in relation to each plot. According to our cadaver study, for bone side, center of fovea is better, no matter radial side or ulnar side. For TFCC side, ulnar side and slightly dorsal is better. This study is published on the journal Distal. In 1993, Bade reported relationship between recess and fovea. So appropriate entry point would be just dorsal and a larger recess seen from RCJ. A slightly spinated position is easy to insert the needle to center of fovea because of this figure. If you feel difficult to find out presthyroid recess and ulnar styloid, you'd better to insert needle from Volar and the dorsal styloid so you can see decide target point easily. Around the outlet of stitcher needle, dorsal sensory branch of ulnar nerve must be reflected meticulously. Under general anesthesia, DLG instability is elicited with manual stress. DLG instability was disappeared after repair of fovea attachment. A postoperative protocol, the wrist is immobilized about 3 weeks using long arm cast. After that, wrist active arm range of motion exercise is allowed in the 3 weeks. Passive range of motion starts 6 weeks after operation. Sometimes this type of sprint is very useful. When we insert the needle at the correct position, it means isometric point. Postoperative CT reveals the whole of ulna is located just larger fovea. The patient sutured with isometric point could get good results. We reviewed traumatic 102 cases of operated with isometric inside-out technique from 2014 to 2017. Average age was 33.5 years old. Average the follow-up period was more than 1 year. We evaluated 4 lists. Average the BOS improved from 8.8 preoperatively to 0.8 postoperatively. Averaged clinical score was 93.1 points. Pronation and spination were improved, especially on acquired to regain spination. Instability before operation disappeared in all cases. 18 cases of positive ulnar carpal stress tests before operation disappeared except for 2 cases. Almost patients returned to previous occupation. As there were 2 cases of superficial ulnar nerve irritation and disappeared within 3 months. For take-home message, it is important to make diagnosis precisely according to patient's history and the meticulous physical findings and the MRI or ultrasound before operation. From radiocarpal joint, check TFCC using trampoline, hook, and floating sign. You'd better to introduce DLG scope for definitive diagnosis. Insert the scope from larger DLG portal and check fovea using probe or 2.0 millimeter shaver. Enough debridement for fovea side is very important to reattach a TFCC. If you can use DLG scope, shaving through the ulnar DLG portal is very useful. Suture tape woven with fiber wire is better used during inside-out technique through the curved guide with passing wire. Thank you for your attention.
Thank you, sir. Thank you very much for that insightful presentation at this late hour from Japan. We would take some questions, but after the second talk by Dr. Darshan. So we will combine both the speakers and then we will take some questions, sir. So I have the honor of introducing my colleague and friend, Dr. Darshan Jain, who's a consultant hand surgeon from Bangalore, from Ramaya Medical College. He finished his MBBS in 2005 and finished his MS Orthopedics from KMC Manipal. He's one of the few people to finish the FNB course, the prestigious FNB course from Ganga Hospital, which is a 2-year comprehensive course. And he also followed that up with a fellowship in National University Hospital, Singapore. So he's going to be talking to us about scapholunate injuries. So I would like to hand over to Dr. Darshan Jain to go ahead with the talk. Thank you.
Is it visible?
Yes, we can see loud and we can hear you. Please go ahead. Yeah.
Thank you, Dr. Kannan, for that introduction. And I'm really delighted and honored to be a part of this webinar and sharing my talk with some of those biggies in the hand surgery. My session, and also thank the Bangalore Orthopaedic Society as well. So my talk is going to be on chronic scapholunate ligament injuries, management by ligament reconstruction. So it's quite a specific topic because SL injury per se can drag on and there's so much variations in management. I would speak on the ligament reconstruction and the surgical technique mainly. So as we know, the scapholunate ligament comprises of 3 parts. That's the dorsal fragment, the central or the proximal, and the distal or the volar fragment. So out of this, why I'm sure this is important is because of all these 3 segments, the dorsal is the one which needs attention and which is the most strongest of them. So the volar one or the proximal one, if there is a tear, so need not be or will not be so much symptomatic. But once you have a dorsal tear, these are the ones which are more symptomatic. So it has got the extraosseous blood supply from the radial artery entering the dorsal ridge, as well as few blood supply from the radioscapholunate ligament. So this is a pattern of injury which is commonly seen. So usually it is injured from the most common type is from the avulsion from the scaphoid, that is 42%. And the type 2 will be the 16%, that is from the lunate. And the mid-substance tear will be the approximately 20%. And a mid-substance tear or a stretching of these ligaments or the lax is almost 22%. So the other important part of this, whenever you are addressing the scapholunate ligaments, are the secondary stabilizers. This is called as STT or the scaphotrapezial trapezoidal ligament, and the scaphocapitate ligament, and the radioscaphocapitate ligaments. These are the secondary stabilizers. This is quite important when we are talking for the scapholunate because these determine the amount of displacement as well as the symptoms as well. And these also need to be addressed when you're planning for a ligament reconstruction or if the wrist has to be stable enough to absorb the load. So let us see what happens exactly whenever you have a fall, an outstretched hand and the dorsiflexion of the wrist. So once you have the fall, mainly you can see the lunate is stabilized with a strong ligaments arising from the radius, whereas the distal pole of the scaphoid is from the ligaments which are arising from the scaphoid to the trapezium. These are the 2 stabilizers. So the force energy is transmitted between these 2, the scaphoid and the lunate. So the first, once the injury happens, that's the ligament, the blue ligament. So first the volar side breaks off, that's the yellow part. Then the dorsal part breaks off, that's the green part. So as the force is transmitted. So some of the tests what we use for the, this thing is a Watson test. Basically you stabilize the wrist in one hand with a thumb forcing the pressure on the tubercle of the scaphoid. And you, from the ulnar side, you deviate towards the radial side, trying to press the scaphoid dorsally. And once you release off the pressure, the dorsally subluxed scaphoid falls back into its place. That is the Watson test. And the scapholunate ballotment test, where you stabilize the scaphoid in one hand and whereas the lunate with the other hand and try to ballot it. That's a pain, reproduction of the pain is will be there. That is, these are the two tests for the scapholunate ligament injuries. And when you see for the X-ray, what do you basically you ask for a true PA and lateral views. So you look for the scapholunate interval, which is normally should not exceed 3 millimeter when compared to the other side, or a more than 5 millimeter is typical of the scapholunate injury. And you can see that is called as a Terry-Thomas sign as well. And there is the ring sign. This is usually seen whenever the secondary stabilizers are also involved. So this is a typical of those findings. And the normal radioscaphoid angle, that is on one line along the scaphoid and the other line along the volar tubercle, as well as the most volar part of the proximal part of the scaphoid. You draw this line, normally it should be less than 45 degrees. The other angle is the scapholunate angle. That is the angle drawn between the scaphoid axis and the tip of the lunate on the both dorsal and volar side, and the perpendicular to it. Normally it should be less than 45 degrees. This is a typical X-ray wherein a scapholunate, this slide shows a typical X-ray wherein the scapholunate is injured with even the injury of the secondary stabilizers. Even before the MRI is done, you could take an idea. So this is how an MRI looks, the diastasis between the scaphoid and the lunate. That was a case which I'm going to discuss the technique were the same X-rays which I showed you. When you see an MRI, it's a similar one. When you see there's so much of widening of the scaphoid, and you can see this is a very nice finding wherein the scaphoid seen subluxed from the dorsal rim of them and the dorsally angulated lunate. So this is what is the typical. So that shows an idea that the secondary stabilizers are also gone. The role of wrist arthroscopy in diagnosing these chronic injuries, basically it helps in assessing the status of the scapholunate ligament. That's the site of injury. As I told, dorsal is the more focus of our focus or interest to, if at all it requires surgical part. The articular surface of the scaphoid fossa on the radius and the capitate. So classification, there are various classifications, arthroscopic as well as dynamic, which physiological classification, pre-dynamic, dynamic, static and reducible. That means there's already an injury which is displayed on an X-ray as well, but the fragments can be reduced, or the static and irreducible, and the slack wrist. So our basically focuses on the static and reducible in this, wherein the ligament reconstruction is possible. So what is natural history? Whenever the axially loaded, the capitate tends to divide the scapholunate interval, force it apart. The scaphoid goes into flexion and pronation, whereas the lunotriquital component goes into extension. So this is what is a stage. If at all not treated, what happens is the radial styloid, that's the most prominent part. Then the stage 2 radioscaphoid arthrosis you can have. Then the midcarpal joint is involved and it progresses on. So reconstruction is preferred whenever the complete non-repairable SL injury is there. And the chronic injuries, generally they are more than 3 months. But sometimes we find this even after 2 months or 1.5 months, even then the fragments or the scapholunate ligament is not amenable to repair. You may have to do a reconstruction, wherein I have found some cases like that. And the factors deciding the treatment. So as I told, alignment of the scaphoid, whether it's reducibility and the status of the cartilage. So this is the alignment, what I told you as the scapholunate angle. In this case, and it's usually also stabilizers of the STT and scaphocapitate and radioscaphocapitate ligament is also as well as known whenever you have such severe deformity, that is 110 degrees here. Status of the cartilage, these two you need to see, midcarpal joint and radioscaphoid articulation. There are various options which have been started with, because whenever the surgeries are more, that means the things are still not clear. Whenever the more number of procedures are described, this is one such area. So one of the earliest was Brunelli described, the original one, wherein a lot of modifications have been running through. So this had wherein the slip of the FCR was used, distally based, and it was attached to the bot or dorsally and attached to the radius, whereas this caused loss of palmar flexion, so fell into disrepute. Then modifications were there. Then Van den Ebbe got this modification where he anchored that slip into the lunate. Initially, first one was on this radius. Later on, it was anchored on the lunate. Then Garcia-Elias, this is the procedure which I'm going to demonstrate, which I frequently follow, wherein a strip of FCR is brought through the scaphoid, tunneled it dorsally, weave it to the radiolunotriquetral ligament, and then anchor it back to it. So, Bain described in this another procedure wherein it is weaved along with and brought into the scaphoid. And just imagine 4 anchors, 2 on scaphoid and 2 on lunate. There's a lot of anchors in this. I hardly do this procedure. And there are some more modifications, which was a comprehensive one where you go through the lunate as well, volarly and dorsally, so anchor it securely. So the aim of all these procedures are involving regaining adequate range of movement and regain the ability to carry the physiological loads without yielding to the injuries. So this is a procedure which I do usually. So the augment, mainly this is the Garcia which was described by the augment the palmar and distal connections of the scaphoid. This procedure aims at this one and reconstruct a dorsal scapholunate ligament and reduce or prevent the ulnar translation of the lunate. Why is it called 3 ligaments? Basically, it aims at or enhances or replicates the action of these 3 ligaments, that is STT, dorsal, SL, and dorsal radiotriquetral ligament. So this is the outline of the procedure. You take the distally based FCR, bring it out dorsally, weave it through the radiolunotriquetral and anchor it towards and stabilize with scaphoid. So this is what is the procedure. You take the distally based almost 8 to 10 centimeters of this. This is the position of the tunnel. You drive it dorsally through that. Once you do that, then you bring it across the radiotriquetral, you go out and go back, anchor it to itself. However, the position of the tunnel is quite critical. There are various studies on this. So this is the position of so it should cross from the distal pole going to the proximal pole. That's the position typically preferred. So this is one of those such video, which I'm this is a guy who came presented with the pain in the and swelling and fall on outstretched hand right side. And surprisingly, he demonstrated this deformity. He presented this clunk to us. He reduced my work. He showed, look at this, I can reduce it. And this is what is, it pops back. So basically he's trying to stabilize the scaphoid. This was a range of movement, good range of movement, but that instability was one bothering him. And this is a typical splaying of the scapholunate interval with the ring sign. These x-rays, which we already discussed, some of these MRI findings as well. So this is a basically dorsal approach. So you identify that is what I'm palpating for the lissus tubercle and taking out the EPL out of the third compartment. And then you make the Berger approach dorsal. You make a dorsal capsulotomy. Open that part. Then you identify, once you open, you can see the scaphoid and the lunate. So once you identify that the interval, then you take a distally based FCR, that's the FCR sheath which we are incising. At least 8 to 10 centimeter of the FCR sheath is required so that you can handle it well when you want to transfer it and adequate you need for tensioning it adequately. That's SS wire I'm passing through the sheath. You could use a thin tendon tunneler as well as this, okay. So basically you make this slip on the ulnar side, basically because the FCR turns around almost 90 degrees when it goes distally as well. So you cheese out that part of the tendon. So you take a bite of that. So you release that. And then you withdraw it distally. And that's how you take it out, distal based FCR. Care should be taken that you don't incise the FCR here. So you identify the tuberosity of the scaphoid. That's the tuberosity of the scaphoid. You mark that because you need to now you make a tunnel through that. You reduce the scaphoid. This is you're viewing dorsally. You reduce the scapholunate interval there. That's a scaphoid which I'm reducing, trying to reduce it. That's the capitate as well. This is a scaphoid which I'm trying to rocket and reduce it. Once I'm making a dorsal thin anchor. This is for the anchoring of the anchor on the dorsum of the lunate. So I withdraw the distally based FCR from volar side to dorsal side. A 2 mm tunnel is minimally required, at least. This is freshening of the dorsal surface of the lunate. Then I anchor that on that, and I weave this FCR tendon. This is the anchor usually use Micromatic or the 1.8 mm anchors, or at least a 1 mm anchor. More than 1.8 mm is not required. This is a metallic anchor which I'm using. Anchor it on that. So once I tension it, I stabilize these parts with the K-wires and then go on to repair these ligament as well. So once that is done, you close the dorsal and the volar capsule. This is the immediate post-op. I have used an accessory anchor as well as the capitate to anchor the ligament as well. This is the correction which I tend to overcorrect it a little bit because there is chance of stretching of these ligaments. This is the range of movement subsequently. And this is the follow-up. You see, once the wire is out, this is a tunnel, and this is the well restored. This is 6 months follow-up after surgery. So this is the position of the tunnel which I was telling. So you start with the distal pole of the tuberosity, and this is quite critical. You can use a needle to locate the tunnel and check it on the C-arm. So that's the one which is the needle which is going through the tunnel, and this is the interval which I need to approximate. I can rock it as well once I use that. I can check that, close it, then stabilize with the K-wire, then pass the FCR tendon. So these are the anchors, as I told, Micromatic 1.8 or 1 mm. These are the sutureless anchors. All suture, I mean to say 1 mm, that is also quite good. So post-op rehab, I use short arm thumb spica cast for 6 weeks. Removal of the wires is by 6 weeks. And start with, once you take out that, dart throwing movements are the ones which you start with, and then mobilization, go on Palmar and dorsiflexion. Strengthening exercises is only started by 3 months, and never allow any contact sport for up to 6 months post-operatively. There are other procedures, that is RASL, that's reduction and association of the scaphoid and lunate, described by the Rosenwasser. Some of these shortcomings were early loss of reduction, avascular necrosis of scaphoid. Basically, we are not trying to restore the biology here, but stabilizing with just an implant. And the other one more method was a SLAM method, that's a scapholunate access method. I have no experience. These devices or the implants are not available, but wherein the tendon graft is secured with a lunate with a graft anchor, and an interference screw is placed with a drill hole on the radial side. But this has given some reasonably good results. A lot of them are doing this as well. So take-in mosaic is like 3LT procedure. This addresses both the distal and the proximal port of the scaphoid. That's why I prefer this, and reconstruct a dorsal portion of the SL. Tunnel in the vascular portion of the bone, that is quite good. So reduces the ulnar translation of the lunate, which is another important point which we need to achieve whenever we are trying, rather than just trying to bridge the gap between the scapholunate. But disadvantage is technically demanding. So overall, what can we expect with a good procedure? That which means you should be able to get 80% range of movement and a grip strength of 80%. That is the ideal outcome of this procedure. Anything more than that is welcome. But there is one of the disadvantages. There is a possibility, if at all, there could be a stretching of these ligaments as well. That is one of the disadvantages. Thank you.
Thank you very much, Dr. Darshan. That was an elegant demonstration of the procedure. It's one of the more commonly done procedures for scapholunate dissociation. Dr. Vamsi has a question for you.
Yes.
What do you do about the volar scapholunate portion? I mean, we are trying to reconstruct the dorsal portion, of course.
Yeah.
But do you have to do anything about the volar portion of the scapholunate ligament? That is his question.
The ligament per se, I don't address the ligament per se, but you are taken care of the distal pole of the scaphoid. That is what I would say, because I usually address only the dorsal port. But if at all you want to volarly also address, only way to make a tunnel through and through to the lunate and come back and weave it back to the FCR volar wards. I don't do this.
Yeah, I personally have a question is, even the 3LT procedure in literature has been shown to, that is a scapholunate dissociation over a period of time opens out again. I mean,
yeah, that's one of the disadvantages was I was telling you, mentioning over a long period, I guess.
Yes. Okay. So we have some questions for Dr. Keiji from the, Dr. Diego, please go ahead. Please go ahead, Dr. Diego.
Yes, I have a comment about the 3LT reconstruction. Dr. Garcia Elias, who has been done that, doesn't do it anymore. He's trying, the problem is the ulnar translation of the lunate. If you have in the X-ray scapholunate dissociation and 50% of the lunate, a little bit more, is ulnarly translate, don't do that operation because you have a bad result. So what he's doing now is he's doing a tenodesis called circular. It's very complicated. He's going around the triquetrum and lunate and back again to close the gap and to control the ulnar translation of the lunate and the triquetrum towards ulnar. So probably the risky case would be for the indication of 3LT reconstruction is if you have increased ulnar translation of the lunate, better not do it. My own experience has been to use distally stripped base of the extensor carpi brevis, and do a dorsal sling, reconstructing the dorsal part, and putting a Herbert screw on the volar side across. It's not the wrestle procedure, it's just a temporary screw fixation of the, and I had always this discussion with Dr. Rosenmass. You have to do something about the biology, you have to reconstruct or shave or put something biologic in, but you can't just put a screw across. But I used always the screw across when Herbert started doing that for subacute Scapholunate dissociations in Australia, and we've used that as a temporary fixation for about 3 months. 3 months up to 6 months. When we saw a little bit of osteolysis around the screw threads, we took it out. And we thought that maintaining the compression between both bones with the screw would give some more time to the transplanted tissues to remodel into a very strong scar tissue. And that's you can get with just K-wire fixation for 8 to 12 weeks and then let them move. Usually you get that's why the people started doing now the volar and dorsal reconstruction like BCO and Dr. Corellia also. Thank you.
Thank you. It probably tells a lot about the procedure and the condition that there is no no single solution to the problem. Please, Dr. Kishan, please go ahead.
Yeah. Actually, I have a question for Professor Diego, sir. Sir, actually, what you are telling about reconstructing both the volar and dorsal side, and what kind of what do you call the tension you are going to provide while suturing, anchoring it, and in what position of the wrist it needs to be anchored?
That's a question to me?
Yes, sir.
Yeah, well, usually you have to, I would put it in maximal tension because you have at the beginning, like any tendon transfer or a tendon suture, you lose a bit the initial tension that you put with sutures. So I will use maximal tension to start with and to immobilize the wrist in neutral position for 6 to 8 weeks.
Okay, no deviation of the wrist.
No deviation, it's in zero. Zero. How about that?
Okay, sure.
I have a couple of questions from the audience to Dr. Keiji. This is from Dr. Kiran Sashi from CMC Vellore. So the question he's asking is, what is the size of the scope that you use for DRUJ arthroscopy?
You would better to use a 1.9 millimeter. It's a very small area space, so you'd better to use 1.9 millimeter.
And the second question that Dr. Kiran Sashi is asking is, do you at any point of time do an inside-out procedure, and do you have any indication for doing an inside-out procedure?
Yeah, acute case and the chronic case, I always use inside-out technique. It's very this is a very advantage compared to the outside-in. Sometimes outside-in technique misdiagnose to the direction to the TFCC side. Bone side is correct, but TFCC side is sometimes too much radial side and the dorsal side to use the outside-in technique. But the inside-out technique is correct position of the TFC side. But be careful to penetrate the bone side. the spination to reduce the position a little bit neutral position is better because of the styloid is moved to the Volar side. Spination position is styloid is moved to the dorsal side. It's not easy to insert the needle or to correct the position. Do you understand?
Thank you very much, sir. Thank you. One more question for you is that what if you find an associated lunate chondromalacia? Do you address it, or what do you do about it, sir?
It means abutment syndrome.
Exactly. You have a combination of an abutment and a TFCC tear. How do you address them? Is the question.
If there is a DRG instability, so you'd better to combine to the ulnar shortening. But if there is no instability, you'd better to select the wafer method. Penetrate the TFCC like a 1A and removal of the distal end of the ulnar.
Thank you very much, sir. We have one question for Professor Diego. Dr. Uday is asking, what are the complications of dorsal plating? I mean, have you seen a lot of tendinitis, tendon ruptures? Because we find that we don't have the right implants in India, but we are wondering whether the implants that you use cause these kind of problems. Do you remove it all the time, and when do you remove these plates? And what are the complications that you find with this?
Okay, at the beginning, the only thing we had was the 3.5 AO plates way back, like 20 years ago. Those plates and then the pipe plate, the contour and the profile were terrible. So we always got tendinitis. Actually, what we're doing was doing a flap of the dorsal retinaculum to cover the plate underneath the extensor tendons. So one thing is about if you do that retinacular flap with a 3-4 approach to the dorsal radius, you might get to cover these implants. The new implants, they're all low profile. So the dorsal plates that we use is just for the dorsal ulnar fragment. They're very small, so it's not a problem anymore. If I have good bone quality, the fragment of the radial styloid you can fix with screws, screws to the radial styloid, and you have very good fixation. So I don't think you need all the time what they call the radial column plate. That one's the problem with the first dorsal compartment. The radial column plate, that one's the one that usually comes out, but the dorsal ulnar plate now. And a very big dorsal plate to fix everything on dorsal, I don't use anymore. Because you can do most of that work from volume.
So one final question for Professor. Do you have any strict indications for dual plating? That is using a volar and a dorsal plate.
Yes.
Do you have?
Yes. I showed an example in my talk. Is when you have a 4-part fracture and you do fragment-specific fixation, you can do the volar ulnar fragment with a small little plate. Then you can put 2 screws on the radial styloid and a small plate on the dorsal ulnar fragment. That's what we call fragment-specific. But I don't do 2 sandwich plates, 2 big things with a lot of metal that when you take the X-ray, you don't know what's happening in there, but it's all white.
Thank you, Prof. That was excellent. We had a great evening. All of us enjoyed this. Now I would request Professor Madan. Yeah, we have one more question.
Can I ask one question?
Please,
yeah.
Sir.
Can I ask one question, sir? Professor,
Yes.
The question is, literature is very much confusing. And literature says that there are so many complications with the plates. And the X-ray findings and the functional result does not correlate even in the literature. So what should be the take home?
Well, take home is,
because
I think,
the series which was series published were saying that anatomy is must. Now series is said the anatomy is not must. Anatomy has nothing to do with the functional result.
no. I think the basic concepts in fracture treatment is always the same. If you're going to open something, you have to get an anatomic reduction first. Then you have to do a provisional fixation with K-wires. And then you decide what to put on. Usually these papers in the literature, they're influenced by the industry, and they're trying to sell implants. But actually, it's logical that you have to take, on the dorsal side, where you have very little space between the extensor tendons and the bone, something very, very low profile. On the volar side, you can use bigger implants because there's more space and you can cover it with a pronator quadratus. But I don't think it's logical not to think too much what the literature says, but your own experience and follow the basic principle. Reduce anatomically and fix stable with the implants that are adequate for that anatomic part of the skeleton. That's it.
What is the role of just reduction and K-wire and joint sparing external fixator and not doing plating?
Well, I think it's a rule, as I said in my last slide, don't throw the fixators away, because if you look at the first papers comparing volar plate fixation, fragment specific, and X-fix and K-wires, at 1 year, the functional results were actually the same in all. The pros and cons of every method. If you see, okay, an X-fix, you can have more pin tract infection problems. With a plate, you can have more tendon problems. Even with volar plates that are prominent on the volar side, you can get the flexor polysesonous tendinitis because you're not putting them below the watershed lines and so on, so on, so on. So if you respect the rules with every method, you can get exactly the same results in the long run.
Okay. Thank you, sir.
Thank you, Prof.